Welcome to the deep dive. If you've been around horses for, well, any length of time, you've probably heard terms like tying up, maybe azoturia, or that old classic Monday morning sickness. They're thrown around, but honestly, they can be pretty confusing, maybe even alarming if it happens to your horse. So today, we're going to cut through that confusion. We're talking about equine exertional rhabdomyolysis, ER for short. Our goal here is to give you a real shortcut to understanding this, well, pretty complex muscle issue in horses. We want to go beyond those common names. We'll dig into what's actually happening underneath, how it's diagnosed, treated, and crucially for you, how you might be able to prevent it. Think of it as your guide to managing this.
And that understanding is so key. Because ER, it's not just one thing, it's really a syndrome, meaning it has multiple possible causes. Getting the specific diagnosis right is, well, it's absolutely critical for managing it effectively in the long run. Today, we're pulling from a couple of really solid sources, a specialist-level study guide and another guide focused on managing muscle necrosis. These really let us get into the necessary detail. So fundamentally, equine exertional rhabdomyolysis, or ER, is a syndrome. It's characterized by the acute breakdown, basically, damage to skeletal muscle tissue that's associated with exercise. What you see on the outside is often muscle pain, stiffness, maybe cramping. But inside, what's happening is the release of muscle proteins, things like CK, that's creatine kinase, AST, aspartate aminotransferase, and myoglobin, into the horse's bloodstream.
Okay, so those older terms you hear everywhere, like tying up, where do they fit in now? Are they just outdated?
That's a really good question. Terms like tying up, azoturia, Monday morning sickness, set fast, they're essentially historical synonyms. They describe the signs, or when it might happen. But exertional rhabdomyolysis, the medical term, is preferred now because it actually describes the process, the muscle breakdown itself. It's much more precise about what's physically occurring.
That makes sense. It's describing the what, not just the when or how it looks. And it sounds like, based on what you said about multiple causes, we can't just treat all ER the same way.
Exactly right. We generally split ER into two main categories, and this split is really based on recurrence, does it happen often, and the underlying cause. So first up, you've got sporadic exertional rhabdomyolysis. This means single episodes, or maybe very infrequent ones, happening in horses that don't have an underlying genetic issue making them prone to it. These episodes are usually triggered by sort of external factors that just push the muscle too hard beyond its current capacity, or maybe cause some direct injury. Things like overexertion are a big one. The exercise intensity or how long they work just exceeds their conditioning level. That classic weekend warrior situation you sometimes see.
Ah, yeah, the horse that does nothing all week and then goes for a huge ride on Saturday.
Exactly. Also, not warming up properly or skipping the cool down. Dietary imbalances are huge too. Think high carbohydrate, low fiber diets, especially if that's combined with not enough exercise or periods of rest followed by work. That's your classic Monday morning disease, high grain feed on rest days, then work. Then there are electrolyte imbalances, sodium, potassium, calcium, magnesium levels being off. Dehydration is a factor. Heat and humidity certainly don't help. Even stress or excitement can play a role. Or if the horse has some other illness like a fever or viral myositis. And sometimes, though rarely the only cause, a vitamin E or selenium deficiency could contribute.
Okay, that weekend warrior thing really paints a picture. But what about the horses where it seems to happen without that obvious overdoing it, the ones that tie up repeatedly? That sounds like something deeper is going on, right?
Precisely. And that's where it gets, well, really interesting clinically speaking. That leads us to chronic exertional rhabdomyolysis. This is characterized by recurrent episodes, often triggered by even pretty mild exertion. And it's because there's an underlying inherent muscle disorder, often genetic. These horses are basically predisposed. And within chronic ER, there are several distinct forms we need to talk about. First, there's recurrent exertional rhabdomyolysis, or RER. We see this mainly in thoroughbreds, especially fillies seem prone, but also standard breds and Arabians. The current thinking is it's an inherited issue with how calcium is regulated inside the muscle cells. It messes up normal contraction and relaxation triggers, often excitement, stress, or that scenario of forced rest while still getting a full high-energy ration. Clinically, you often see it in young, maybe nervous fillies in race training, especially on high-grain diets. It affects something like 5 to 7% of racing thoroughbreds, with young females, maybe 2-3 years old, being more susceptible initially.
An internal calcium problem. Okay. What else falls under chronic?
Next big one is polysaccharide storage myopathy, or PSSM. This is an inherited problem with how the horse metabolizes and stores glycogen, which is muscle fuel. It leads to abnormal amounts or abnormal types of polysaccharide accumulating in the muscle. And PSSM itself has two main types we recognize right now. Type 1 PSSM, or PSSM1, has a known genetic cause. It's a dominant mutation in a gene called GYS1. This gene mutation leads to too much glycogen being made, and this abnormal polysaccharide builds up. You see PSSM1 a lot in quarter horses and related breeds, paints, Appaloosas, also draft breeds like Belgians and Percherons and some warm bloods. The numbers are pretty significant, maybe 6 to 10% of quarter horses overall, but way higher in certain lines like halter quarter horses, maybe up to 28%. And in Belgian drafts, it can approach 40%. Average age of onset in quarter horses around 5 years old.
Wow, 40% in Belgians, that's huge. And type 2.
Right. Type 2 PSSM, or PSSM2, is basically horses that show the signs of PSSM, and you see similar things on a muscle biopsy, but they don't have that GYS1 mutation. The exact genetic cause, or causes probably, for PSSM2 are still under investigation. We see it in various breeds.
Okay, so PSSM is about fuel storage. What else?
Then there's malignant hyperthermia, or MH. This is another one with a known genetic basis, a dominant mutation in the RYR1 gene. MH causes this acute, really severe, often fatal rhabdomyolysis. It's typically triggered by certain anesthetic gases like halophane or sometimes just extreme stress. These horses get incredibly hot, very rigid. Their body chemistry gets very acidic. It's a crisis. We see MH mainly in quarter horses and related breeds too. And an important point, horses that have two copies of the MH mutation, or horses that unfortunately have both PSM1 and MH mutations, tend to get much more severe signs.
Goodness, that sounds terrifying. Is that the last major chronic type?
The last one we'll cover today is myofibrillar myopathy, or MFM. This tends to be seen more in warm bloods and Arabians, often in slightly older endurance horses, say over 5 years old. The underlying issue here seems to be abnormal clumping of structural proteins like desmin inside the muscle fibers. Clinically, MFM can be a bit different. You might see things like mild shifting lameness, poor performance or exercise intolerance, maybe some muscle loss. But interestingly, without huge spikes in the CK enzyme in every single episode, that can make it trickier to spot just with blood work. Triggers can be diet, exercise changes, or even just the aging process.
Wow, okay. That's a lot of different mechanisms. RER with calcium, PSSM with glycogen, MH with the RYR1 gene, MFM with structural proteins. For the average owner listening, what's the big takeaway here? Is it just knowing that tying up isn't simple, or is there something more practical?
I think the biggest practical takeaway is that diagnosis matters a lot. Because the long-term management for, say, RER is different from PSSM. Knowing the specific type, often through genetic testing or a muscle biopsy, is what lets you and your vet create a really targeted, effective management plan. It moves you beyond guesswork.
Right, precision medicine for horses, basically.
Yeah.
It's amazing how these different triggers, diet, exercise, stress, genetics, all seem to lead to muscle damage. But what is that damage process? Like at the cellular level, what's the common thread when a horse ties up, regardless of the specific cause?
That's a great point. Despite the varied starting points, the downstream effects on the muscle cell have similarities. It nearly always involves damage to the muscle cell membrane. This breach lets intracellular stuff leak out. That's your CK, AST, myoglobin, electrolytes into the blood. There's also often a problem with calcium regulation inside the cell. Calcium is crucial for contraction and relaxation. If it's not handled properly, muscles can contract abnormally or fail to relax, leading to stiffness and cramping. You also get an energy metabolism imbalance. Either the cell can't produce enough energy, ATP, or it can't use it efficiently. Lactic acid does accumulate, but we now understand it's more of a consequence of this messed up metabolism in most ER forms, not the primary driver like we used to think, especially in chronic types. And then, critically, there's myoglobinuria. Myoglobin is the protein that carries oxygen in muscle. When cells break down, it floods into the blood and then hits the kidneys. Too much myoglobin can damage the kidney tubules, potentially leading to kidney failure, especially if the horse is dehydrated. That's a major concern.
So it's a cascade, really. Membrane damage, calcium chaos, energy crisis, and then the potentially toxic myoglobin release. Okay, that really drives home why it's not just muscle soreness. Given this internal breakdown, what should owners be watching for? You mentioned stiffness, but what does that spectrum look like from, something's a bit off to, oh no, this is serious?
Yeah, the signs definitely exist on a spectrum, and they usually pop up during or soon after exercise. In a mild case, you might just notice some stiffness. Maybe their stride shortens up, looks a bit stilted. They might seem reluctant to move forward, almost like they're a bit lame, but you can't pinpoint where. You could see some muscle twitching. We call it fasciculations, often in the flank or hindquarter muscles. Maybe some subtle sweating or mild anxiety. And it's important to know sometimes it's subclinical, meaning the only sign is elevated muscle enzymes in the blood, without obvious outward signs. Endurance horses are sometimes prone to this.
Okay, so mild can be pretty subtle. What does moderate look like?
Okay. Moderate cases are clearer. The horse is obviously reluctant, maybe refuses to move. The muscles, especially over the back and hindquarters, will feel firm, tense, painful if you palpate them. You'll usually see more obvious sweating, often generalized. Their heart rate and breathing rate will likely be up. That's tachycardia and tachypnea because of the pain. Muscle tremors might be visible, and the urine might start to look a bit dark, like tea maybe. That's the myoglobin starting to show up.
And the severe end, the real crisis.
A severe episode, what used to be called azoturia, or an acute rhabdomyolysis crisis, is absolutely an emergency. The horse shows profound stiffness, might be physically unable to move. Sometimes they'll go down, become recumbent, and refuse to get up. There's severe pain, obvious distress, usually profuse sweating. The urine becomes very dark, like cola or dark brown. That's frank myoglobinuria. You might see signs the kidneys are struggling, like decreased or no urine production. And in the worst cases, it can progress to shock, collapse, and even death. And remember, these signs can appear anytime from just before exercise starts to hours afterwards.
That range is just, wow, from subtle stiffness to a life-threatening crisis. It really underlines why owners need to be observant and why vets have to do some serious detective work. Like you said, it's definitely not something you can just diagnose from a quick Google search. So if an owner sees these signs, what's the diagnostic process? How does the vet confirm it's ER and then figure out which kind it might be?
Absolutely. The detective work is crucial. The approach is pretty methodical. First, confirm muscle damage is happening, then try to pinpoint the underlying cause or type. It always starts with a really thorough history. The vet will ask about the horse's exercise, what kind, how intense, how long, any recent changes, what's the diet, have there been previous episodes, what age did they start. Breed is important. Any known family history, even the horse's temperament, is it anxious or excitable?
So getting the whole picture first.
Exactly. Then comes a careful physical examination, observing how the horse stands and moves, if they can move, looking for those muscle twitches, palpating the big muscle groups back, hindquarters, checking for firmness, pain, heat, or swelling, assessing hydration, checking heart rate, respiratory rate, temperature. Then, blood work is essential. We're looking specifically at muscle enzymes. Creatine kinase, CK, is the most sensitive marker for acute muscle damage. It starts rising within a few hours, peaks around 12-24 hours, and usually gets back to normal in 3 to 7 days if the damage stops. Aspartate aminotransferase, AST, also indicates muscle damage, but it hangs around longer, stays elevated for maybe weeks, so it's helpful for looking at more chronic issues or tracking recovery over time. LDH, lactate dehydrogenase, might be up too, but it's less specific to muscle. We also check electrolytes, sodium, potassium, chloride, calcium, magnesium for imbalances, and very importantly, kidney values, BUN and creatinine, to see if the kidneys are being affected by myoglobin.
Okay, blood tests are key. What else? Urine?
Yes, urinalysis is important, mainly to check for that myoglobinuria. We look for pigment in the urine. A dipstick test will be positive for blood, but when you look under the microscope, you won't see many red blood cells. That tells you the pigment is coming from muscle breakdown, not bleeding. For the chronic types, we might move to genetic testing. We can test blood or hair root samples for the specific mutations causing PSSM1, GYS1, and malignant hyperthermia, RYR1. But it's important to note, as of now, we don't have specific genetic tests for RER or for PSSM2, so diagnosing those relies more on the clinical picture, the enzyme results, and sometimes muscle biopsy.
Muscle biopsy, right. When would a vet decide to do that?
A muscle biopsy is usually considered if a horse has recurrent ER, if PSSM2 or MFM is suspected, or sometimes just to help differentiate between RER and PSSM if other tests aren't conclusive. A small piece of muscle is taken, often from the hind end, like the semimembranosus muscle. It's sent off for histopathology, basically looking at the tissue structure under a microscope, and that can reveal specific things. Abnormal polysaccharide deposits in PSSM1, characteristic glycogen aggregates in PSSM2, protein clumps in MFM, or sometimes just non-specific signs of damage or inflammation, which might suggest RER.
And what about that exercise test you mentioned?
Right, the exercise challenge test. This is sometimes used if ER is suspected, but the horse looks normal at rest, maybe for diagnosing subclinical cases. The horse does a standardized amount of exercise, like 15 minutes of trotting and cantering. Blood is drawn for CK levels before the exercise, and then again about 4 to 6 hours afterwards. A significant jump in CK after exercise, say over 800 units per liter, strongly suggests the horse has an underlying susceptibility to ER.
Okay, let's shift gears to treatment. If a horse is in the middle of an acute episode, that sounds like panic stations for the owner. What are the absolute first things someone should do? And then what will the vet likely do when they arrive?
Yes, immediate action by the owner can make a real difference. The absolute first thing, stop exercise immediately. Don't push them. Don't make them walk back to the barn if it's far. If possible and safe, move them very gently to a nearby stall or shelter. If not, treat them where they stand. Keep them warm if it's cold. Maybe throw a blanket on. If they're hot and sweating profusely, try to cool them down gently with water. Offer fresh water, provided they can swallow normally. And the most crucial step, call your veterinarian immediately. This is not a wait-and-see situation.
Got it. Stop, assess, comfort, call vet. What happens when the vet gets there?
The vet's focus in the acute phase is multifaceted. Pain relief is paramount. They'll likely use NSAIDs, non-steroidal anti-inflammatory drugs like flunixin and medelamine, commonly called Banamine, or phenylbutazone, Bute. Sedation might be needed to calm a distressed horse and can also help with muscle relaxation. Drugs like xylazine, ditomidine, or sometimes acepromazine are used. Acepromazine also helps dilate blood vessels, improving circulation to damaged muscles. For severe pain, opioids might be considered.
Fluids seem like they'd be critical, especially with the kidney risk.
Absolutely. Fluid therapy is often crucial, especially if the horse is dehydrated or has significant myoglobinuria. Intravenous fluids, usually a balanced electrolyte solution like lactated ringers, are given to help flush the myoglobin through the kidneys and prevent acute kidney injury. For milder cases without dehydration, encouraging oral fluids and electrolytes might be enough. Muscle relaxants, like methocarbamol, can be given usually orally to help ease the cramping and stiffness. For horses specifically diagnosed or strongly suspected of having RER, a drug called dantrolene might be used. It works by decreasing calcium release within the muscle cells, targeting the underlying mechanism in RER. Dietary changes are immediate too. All grain and concentrates need to be stopped right away. Just good quality hay or access to pasture initially. You want to remove those high carbohydrate feeds immediately.
And what about rest versus movement?
It's a balance. Initially, strict stall rest for maybe 24 to 48 hours until the acute muscle pain starts to ease. But then, once they're more comfortable, some gentle movement is usually beneficial. Small paddock turnout for several days to a week is often recommended. Prolonged strict stall rest can actually be counterproductive, especially for chronic ER types. The return to any kind of work has to be very gradual, carefully monitored, often guided by follow-up CK blood tests to make sure the muscles are recovering.
Okay, so that's managing the crisis. But for horses prone to this, especially the chronic types, prevention and long-term management are obviously key. What does that involve? Sounds like a big commitment.
It is a commitment, but it's usually very manageable with the right approach. Long-term strategy is really where you make the biggest difference for these horses. It revolves around three main areas: diet, exercise, and environment. First, dietary management. This is huge, especially for PSSM, but relevant for others too. The main goal is to dramatically reduce non-structural carbohydrates, that's NSC, basically starch and sugar. So you want to eliminate or drastically minimize traditional grain mixes, corn, oats, barley, sweet feeds. The foundation of the diet should be high fiber, low NSC forage, good quality grass hay, maybe tested for NSC content or pasture, and ensuring they get enough forage, typically 1.5 to 2% of their body weight daily.
So less grain, more hay. What about energy for working horses?
That's where fat comes in. You replace the carbohydrate calories with fat calories, which provide a cool energy source. Things like rice bran, stabilized, of course, vegetable oils like corn or flaxseed oil, or specially formulated high-fat, low-starch commercial feeds or supplements. You have to introduce fats gradually, though. Electrolyte supplementation is also important, providing free choice loose salt, not just a block, and potentially a balanced electrolyte supplement, especially if the horse is working hard or in hot weather. Antioxidants are often recommended, particularly vitamin E. Natural vitamin E is generally preferred, maybe 1,000 to 5,000 IUs per day, especially for PSSM horses or if hay quality is questionable. Making sure selenium levels are adequate is important too, but you have to be careful not to over-supplement selenium as it can be toxic. And of course, ensuring overall mineral balance.
Okay, diet is number one. What about exercise? You mentioned consistency.
Yes, exercise management is critical. Consistency is the key word. Avoiding long periods of stall rest followed by sudden work is vital. Daily turnout, ideally, or at least some form of light, consistent exercise is really beneficial. Always include a proper warm-up before more strenuous work and a good cool-down afterwards. Conditioning needs to be gradual. Build fitness slowly and steadily. Avoid that weekend warrior pattern completely. For horses prone to RER, which is often triggered by stress or excitement, minimizing stress is part of exercise management. This means trying to provide a calm environment, sticking to a predictable routine. For some RER horses, medication might be part of the plan. Low doses of acepromazine before exercise can sometimes help by providing mild sedation and vasodilation. Dantrolene, given orally about an hour before exercise, can also be effective in preventing RER episodes. Phenytoin is another drug sometimes used, but it's less common and needs careful monitoring.
And the environment piece.
Environmental management ties into the exercise and stress aspects. Basically, minimize stall confinement as much as possible, maximize turnout time, keep routines consistent feeding times, turnout times, exercise times, and create a calm, low-stress environment, especially for those nervy RER types. It's all interconnected.
It really sounds like a holistic approach, diet, exercise, environment, all working together. So considering all this, what's the general outlook? If a horse is diagnosed with ER, what can owners expect long-term? And how do they keep tabs on things?
The prognosis really depends on the type of ER and how well it can be managed. For sporadic ER, the outlook is generally excellent. If the triggering factors are identified and avoided, like adjusting diet, managing exercise better, future episodes can often be completely prevented. For chronic ER, PSSM, RER, MFM, the prognosis for managing the condition and allowing the horse to continue in athletic work is often good to excellent, but it requires strict, lifelong adherence to those tailored management plans. These aren't conditions you cure, you manage them. If the diet or exercise plan slips, relapses are definitely possible. For PSSM specifically, horses that start showing signs later in life often respond well to management. Those that show signs very early, like under a year old, sometimes have a tougher time achieving high levels of athletic function. For malignant hyperthermia, the prognosis during an acute crisis is grave. So for known carriers, the focus is entirely on prevention, avoiding trigger anesthetics, and managing stress. If a horse has very severe repeated episodes despite good management, or if there's significant kidney damage, the prognosis for future athletic use might be poor, and the prognosis related to kidney injury itself is guarded depending on the severity.
So management is key, but vigilance is too. How do owners monitor? Just watching for signs.
Vigilance for clinical signs is definitely number one. Owners become very attuned to subtle stiffness or changes in attitude, but objective monitoring is important too. Periodically rechecking those muscle enzymes, CK and AST, can be really useful. Often, vets recommend checking them 4 to 6 hours after a typical bout of exercise. This helps detect low-grade, subclinical muscle damage, even if the horse looks fine, and it tells you if the current management plan is truly effective or needs adjusting. Regularly monitoring body condition and weight is important too, especially with dietary changes involving high fat. And occasionally, your analysis might be checked if there are any ongoing concerns.
So wrapping this up, it's clear that equine exertional rhabdomyolysis isn't just one thing. It's complex, it has many faces from sporadic incidents to chronic genetic conditions, but the encouraging part is that it is manageable, often very successfully once you get that accurate diagnosis and stick to a consistent, tailored plan.
Absolutely. And what this really means for you, the listener, is that understanding this is empowering. Knowing whether your horse had a sporadic episode versus having, say, PS, SM1, or RER allows you to move beyond just treating symptoms to proactively managing the underlying cause. It lets you make informed decisions about diet, exercise, even breeding choices based on your specific horse's needs. It really shifts the dynamic from being reactive and anxious to being proactive and knowledgeable.
That's a great way to put it. And it leads to a final thought for everyone listening. We've talked a lot about the clear genetic links for several chronic ER forms like PSSM1 and MH. Given that knowledge, what are the bigger implications for how we breed horses? How might selective breeding practices evolve in the future to perhaps reduce the incidence of these conditions and better protect horse health overall? Something to think about. Thank you for joining us for this deep dive. Keep asking questions, keep learning, and always partner closely with your veterinarian when it comes to your horse's health.